Image-guided spinal navigation is a surgical assist technology that has been used to varying degrees since the mid-1990s. But despite proven effectiveness, the adoption of this technology has been slow and inconsistent due primarily to technical and workflow issues that plagued earlier versions. However, as these issues have gradually been resolved, the adoption of image-guided spinal navigation has increased, and it has now become an accepted and reliable technology that facilitates surgery for complex spinal disorders. The overall objectives for developing spinal navigation were to improve the accuracy and precision of pedicle screw insertion and to reduce and in many cases eliminate the need for fluoroscopy. Numerous studies have looked at the screw misplacement rates. These rates have ranged from anywhere from 5 to 21% in various studies. There are immediate consequences of screw misplacement, including neural injury and vascular injury. There are also delayed consequences of screw misplacement that include fixation failure, pseudoarthrosis, and the acceleration of adjacent segment degenerative changes. This particular study looked at 273 patients with over 1,200 pedicle screws inserted. They noted a pedicle breach rate of 20%. They judged that 3.8% of these were severe in degree. They noted more thoracic breaches than lumbar breaches. They also noted that there were more lateral pedicle breaches compared to medial wall pedicle breaches. There was a 5.9% rate of postoperative radiculopathy, and they had revision surgery in 8.4% of their patients. Conventional fluoroscopy has been and still continues to be used to facilitate screw insertion. However, there are some disadvantages with using conventional fluoroscopy. There can be difficulties with positioning the C-arm in some patients, as is seen in this particular patient with two C-arms positioned for odontoid screw fixation surgery. The image quality can be compromised in obese patients undergoing lumbar surgery and in those individuals undergoing upper thoracic surgery. The fluoroscopic images presented are only biplanar. They're either AP lateral or oblique images. There is no axial view, which can demonstrate the laterality or medial breach of a pedicle screw. There's also the added risk of radiation exposure for the patient and on a long-term basis for the surgical team. Several studies have looked at the insertion time and fluoroscopy time used for pedicle screw fixation. This has ranged anywhere from 3.4 seconds to 66 seconds per screw. It's been determined that 1 minute of fluoroscopy has the radiation dosage equivalent of 150 chest x-rays, and that 5 minutes of fluoroscopy has the radiation equivalent of 750 chest x-rays. Rampersad sought to determine the risk for spine surgeons using conventional fluoroscopy. Using 6 cadaver torsos, he inserted 96 pedicle screws from T11 to S1 with fluoroscopy. He measured the radiation dosage with dosimeter badges and compared to other surgeons who are using conventional fluoroscopy, he noted that spine surgeons had a 10 to 12 times increase in radiation dosage exposure compared to these other surgeons. This was felt to be due to the increased dose needed for lumbar spine imaging and also due to backscatter radiation effect. So when it comes to pedicle screw insertion, there are several pertinent questions that need to be asked. How good is good enough? Is 100% accuracy an achievable goal for the insertion of pedicle screws? What is the acceptable rate of screw malposition, neural injury, or vascular injury? And what amount of additional OR time, radiation exposure, or cost is justified in order to avoid these problems. So spinal navigation has its roots in the development of stereotactic cranial surgery in the 1930s. This consisted of attaching a frame to the patient's head to create a reference for the stereotactic procedure for managing intracranial pathology. The use of the frame limited the application to extracranial procedures. However, with the development of frameless navigation in the mid-1980s, this now opened up the opportunity for being able to apply stereotactic principles and techniques to extracranial applications. Although the cranial application used surface fiducials instead of a frame, applying these fiducials for spinal surgery was noted practical. The spine itself comes with its own built-in fiducials, and these are the spinal anatomic surface landmarks that are identified in the field, can be used as a replacement for surface fiducials to serve as a reference point for the navigation procedure. The use of a preoperative CT image data set along with a ultrasonic localizer and later a optical infrared localizer facilitated the application of frameless navigation techniques to spinal surgery. The first papers highlighting the use of frameless navigation for spinal surgery involved looking at 30 patients who underwent the insertion of 150 pedicle screws. They each received a postoperative CT. Satisfactory positioning of the screws was noted in 149 out of 150 screws. This slide demonstrates the clear advantage that spinal navigation has over conventional fluoroscopy. The multiplanar images give the surgeon a much greater degree of spatial and anatomic orientation with which to make an intraoperative judgment as to where the pedicle screw should be inserted. So spinal navigation has been in use since the mid-1990s. It presents to the surgeon multiplanar intraoperative images. It improves the accuracy of screw insertion. It minimizes and in many cases eliminates the need for intraoperative radiation. And it's been applied to several different spinal procedures, including the insertion of pedicle screws in the thoracic and lumbosacral regions, fixation screws in the posterior upper cervical region, transoral surgery, as well as anterior thoracolumbar surgery. Despite the proven effectiveness of spinal navigation, there have been a number of barriers that have prevented its consistent and widespread adoption throughout the field. Initially, this was relatively unfamiliar technology, particularly for orthopedic spine surgeons who had never done stereotactic cranial surgery. There was a requirement for a preoperative CT scan, which was not consistent with the workflow of most spinal surgeons. There was also the tedious workflow associated with the navigation process itself, including the setup of the system, the need for manual registration by the surgeon, and countless computer and system failures that altogether created an increase in the amount of time needed to perform the surgery. Other barriers to adoption included concerns with a difference between the scan in the imaging position versus how the patient was positioned on the table, the fact that the images were not real time, there was no re-imaging option intraoperatively, there were line of sight difficulties between the navigation tools and the overhead camera. The technology was relatively expensive, which brought about questions about clinical value, and there are many surgeons who felt that fluoroscopy just was good enough and that they did not need navigation. But over the course of the last several years, the adoption of this technology has continued to increase. This has been due primarily to continuous technical improvements, to improvements in workflow and ease of use, to consistent, proven clinical effectiveness, to a growing awareness of radiation exposure, particularly with MIS procedures. And there have been a number of different navigation platforms developed for spinal surgery. This slide demonstrates the various spinal navigation platforms available, ranging from the initial platform, which was CT-based navigation, introduced in 1993, followed by fluoroscopic navigation, isocentric fluoroscopic navigation, intraoperative CT navigation, robotic navigation, and more recently, machine vision navigation. Looking at the first platform developed for spinal navigation, the CT-based navigation platform, the advantages of this system was that it required a preoperative CT imaging, which basically eliminated the need for intraoperative radiation, intraoperative imaging time, and there was no field of view limitations. It allowed for preoperative planning, and it presented multiplanar images, in particular the axial image, creating an advantage over conventional biplanar fluoroscopy. The disadvantages for some surgeons was the requirement for a preoperative CT scan being outside their normal workflow, the fact that the registration process was very surgeon dependent. There was no re-imaging option available with CT-based navigation, and it had limited MIS options. Fluoroscopic navigation was the next platform introduced. This was also termed virtual fluoroscopy. It essentially involved obtaining a preoperative fluoroscopic AP and lateral image, and then the navigation information could be superimposed on these images without the need for intraoperative imaging during the procedure. The advantages was that this was relatively familiar technology for those that were comfortable with conventional fluoroscopy. There was no need for a preoperative CT scan. The registration process was automated. There was a reduction in intraoperative radiation compared to conventional fluoroscopy. This could be used for MIS surgery, and there was a re-imaging option available with this technique that was not available with preoperative CT navigation. The disadvantages with fluoroscopic navigation is that it represented basically modified fluoroscopy. There was still some degree of intraoperative imaging time and radiation exposure. There was certainly no axial image presented, and the image quality could be suboptimal, particularly in the upper thoracic region and in the lumbar spine in obese patients. The next iteration of navigation was isocentric fluoroscopic navigation. This was a specially designed C-arm that could obtain a 180-degree sweep with the patient on the table immediately prior to surgery. These images could then be converted into reformatted multiplanar images, which included an axial image. The advantage, again, no need for a preoperative CT. The registration process was automated. Axial plane images were available. It could be used for MIS surgery, and it gave the surgeon an option for re-imaging during surgery. The disadvantages was the intraoperative imaging time needed. There was still radiation exposure to the surgical team. There were field of view limitations, and the image quality was compromised in obese patients and in the upper thoracic region. In 2006, intraoperative CT navigation was introduced. This revitalized what had been a relatively stagnant interest in navigation. Several different intraoperative CT navigation platforms are available. Some are mobile and some are fixed. The advantages of intraoperative CT navigation is that there is no need to obtain a preoperative CT scan. The CT scan is obtained intraoperatively with the patient on the table. The registration process is automated. There is a much greater image quality compared to fluoroscopic navigation and isocentric fluoroscopic navigation. It can be used for all MIS surgical procedures, and there is a re-imaging option. The disadvantages is that it creates a relatively large OR footprint. There is a not insignificant intraoperative imaging time that can range from 8 to 12 minutes. There's radiation exposure. There is a field of view limit that each scan can do no more than 5 to 6 spinal levels. And there's a need to maintain the reference array attached to the spine, because if the array is dislodged after the scan is obtained, the CT scanner needs to be repositioned and another image obtained. And then finally, the cost of intraoperative CT navigation is relatively expensive compared to other navigation platforms. This particular paper alludes to the concerns with doing intraoperative CT navigation at a level distant from where the reference array is attached. For instance, putting screws in at L1 when the reference array is attached at S1. This particular paper looked at 2,200 screws inserted with intraoperative CT navigation, and they noted satisfactory accuracy when the screws were positioned within levels that were no more than 3 levels away from the dynamic reference array. But there were increased errors of screw insertion when the levels inserted were greater than 3 levels away from where the reference array was positioned. Robotic navigation was introduced in 2007. This utilizes preoperative CT images, allows for the creation of a preoperative plan where the screw diameters and lengths are selected. An intraoperative fluoroscopic image is obtained and combined with the CT image. And then during the procedure, a robotic arm moves to the appropriate site, guiding a tool or a drill guide to the entry site and angling the trajectory along the appropriate line for the screw insertion. The advantages of robotic navigation is that it has the robotic surgery appeal. It utilizes and allows the surgeon to do extensive preoperative planning, and it can be used for MIS procedures. The disadvantages is that it requires a frame attachment to the patient. It requires both preoperative CT as well as intraoperative fluoroscopy. And much like the intraoperative CT navigation, it is relatively expensive compared to other navigation platforms. The latest iteration of navigation is machine vision navigation, introduced in 2017. It uses a type of machine vision called structured light technology, which is very similar to what is used with facial recognition technology. It utilizes a preoperative CT scan as its image data set for navigation purposes. Structured light machine vision involves the projection of a light pattern grid onto the exposed surface anatomy of the spine. The degree of light distortion is captured by stereoscopic cameras, and this generates a three-dimensional point cloud, which can then be automatically registered to the stored CT image dataset. The system head of the machine vision platform includes a surgical lamp with an embedded stereoscopic video cameras, a projector system for the grid pattern, and infrared tracking cameras to track the navigation tools. This slide demonstrates what the stereoscopic cameras see from immediately above the surgical field. The virtual reality green triangle indicates that the camera is able to visualize the dynamic reference array. This green triangle disappears when the array is not in clear view. This slide demonstrates the relatively small footprint of the system. The arm is attached to the workstation. The system head can be swung into view immediately over the surgical field, eliminating line of sight issues. These images demonstrate the use of machine vision navigation for thoracic fixation and identification of a thoracic metastatic lesion. These images show other applications for lumbar pedicle screw fixation, iliac wing screw fixation, thoracic screw fixation, and C2 screw fixation. The advantages of machine vision navigation include the fact that there is no intraoperative imaging and therefore no radiation exposure. The registration process is automated, and unlike all other systems, it allows for an easy, efficient, repeatable registration option in case the reference frame is dislodged. There are no field of view limits because the scan obtained is obtained preoperatively and includes all of the pertinent spinal levels. All of this leads to a very rapid and efficient workflow for the navigation process. The disadvantages for machine vision is that there is no intraoperative re-imaging option, and currently there is a limited application to MIS surgery. So as spinal navigation has evolved over the last 2 decades, numerous studies have clearly demonstrated that it provides a greater degree of accuracy and less radiation than conventional fluoroscopy. This particular study looked at 26 prospective studies involving 1,100 patients and over 6,600 pedicle screws. It demonstrated the screw insertion accuracy for different techniques, including freehand insertion, conventional fluoroscopy, fluoroscopic navigation, and CT navigation. And it demonstrated that there was clearly increased safety and accuracy with navigation techniques compared to conventional fluoroscopy or freehand insertion. This paper looked at 30 studies, a total of 9,310 screws inserted, postoperative CTs in each of these patients, and the screw insertion accuracy clearly better with navigation techniques compared to conventional fluoroscopy. This paper looked at the radiation exposure. Pedicle fixation was performed in 38 patients. Radiation dosage was measured in both the fluoroscopy group as well as the navigation group, and there was significantly less radiation with navigation compared to conventional fluoroscopy. The economics of spinal navigation have also been investigated. This paper looked at 502 patients undergoing either intraoperative CT navigation or conventional fluoroscopy. The navigation accuracy was greater than the conventional fluoroscopy accuracy. There was a revision rate of navigation patients of only 0.8% at 1 year, but it was at 6% in the fluoroscopy group at 1 year. And this study concluded that there was a significant cost effectiveness for navigation for high volume spine centers. Some future developments for spinal navigation include the improvement in workflow and efficiency, greater exposure during residency training, which translates into use later on in their career, an awareness of long-term radiation, particularly with MIS procedures, several technological advances that include robotics and augmented reality, an improvement in the cost effectiveness, and an increased application to MIS surgery. So in conclusion, spinal navigation is an established surgical technology that improves surgical accuracy and precision. It reduces and in many cases eliminates the radiation exposure. And there are multiple navigation platforms available. The system continues to evolve and improve, and this will ultimately lead to an increase in the adoption and usage of this technology.